Those of you who are joining us for the first time today, SAMVAD stands for Support, Advocacy, and Mental Health Interventions for Children in Vulnerable Circumstances and Distress. It is a national initiative and integrated resources for child protection, mental health, and psychosocial care. Yeah? And it is located in the Department of Child and Adolescent Psychiatry, NIMHANS, and it is supported by the Ministry of Women and Child Development. We are working in 4 verticals, that is the mental health, the education, child protection, and law and policy. And well, Monday Mood is an initiative to bring together child care workers from all walks of life, thus creating a platform of sharing, learning, and networking through broad areas of expertise and experiences. So today our session will be chaired by our very own Dr. Shekhar Shishadri, who has been working in the field of child mental health and protection for more than 35 years. He was also the former senior professor in child and adolescent psychiatry in NIMHANS, and he's presently our advisor at SAMVAD. So without further ado, I will hand over the time to Sir. Yes, sir, you can take your time.
Thank you very much, June. Very warm welcome to my colleague and the speaker for today's talk, Dr. John Vijay Sagar, Head, Department of Child and Adolescent Psychiatry, NIMHANS. Friends, John has extensive academic, clinical, and research experience of over 20 years with a keen interest in the areas of neurodevelopmental disorders, particularly autism spectrum disorders, pediatric psychopharmacology, adolescent mental health, child abuse, and the neurobiology of child psychiatric disorders are also areas of John's interest. Dr. John has authored 60 research papers in 7 book chapters. He was awarded the prestigious National Institute of Health USA-funded India-US Fogarty Fellowship in 2014 and trained at the McKnight Brain Institute, University of Florida. John was also recently appointed the affiliate faculty at the School of Biological and Population Health Sciences at Oregon State University. Friends, we bring him today to Monday Moods with SAMVAD to talk about and to understand autism spectrum disorders through a lifespan perspective. As you know, 2nd April every year is Autism Awareness Day, and it also marks the beginning of the World Autism Awareness Month, or the Autism Acceptance Month, observed to raise awareness among people about the developmental disorder and to remove the stigma associated with it. We all know that autism is a lifelong neurodevelopmental condition. As a person with autism changes throughout their lives, they are faced with new tasks, new challenges, and new opportunities. Autism at 2 years may look completely different than at 12 years of age or at 17 years. Children may experience exclusion, interpersonal problems, bullying, social isolation, sexuality-related issues. Now, in today's session, John is going to be discussing the developmental lifespan approach, which is predicated on the notion that individual development follows a trajectory over the course of the lifespan, and that autism can impact that trajectory and the subsequent life outcomes experienced by the concerned individual that we're talking about. So to begin with, let's talk about early childhood, preschoolers, kids under the age of 2. And what does early identification and intervention for autism spectrum disorder mean in this age group? There is the need for early identification. There are tools for early identification. There is evidence-based interventions for infants and toddlers. So my opening question, therefore, to John in this session where he brings his many years of experience and his deep interest in this sometimes intriguing disorder. John, where early identification and intervention for ASD is concerned in toddlers and infants. Can you take us through what is the need for early identification? What are the tools for early identification? And what kind of evidence-based interventions do we have for ASD in infants and toddlers? John?
Thank you, sir. Good evening to all, and welcome to this session on autism spectrum disorder, lifespan perspective. At the outset, I thank our SAMVAD team for conceptualizing today's session on autism spectrum disorder. Given this month of April, and as sir mentioned, April 2nd is commemorated as the World Autism Awareness Day. And we can say that the whole month of April is commemorated as the Autism Awareness Month. So autism spectrum disorder, as all of us know, is a complex, heterogeneous neurodevelopmental disorder. And way back in the 1943, Leo Kanner had first observed about 11 children whom he had followed up over a period of several years. And he was the one who first described this constellation of features in a group of 11 children. And subsequently, we know that several changes had taken place in the history. Like initially, we had the terminologies like pervasive developmental disorders, but uniformly, currently, we are using the term autism spectrum disorder. As far as the early identification and early intervention of this complex neurodevelopmental condition is concerned, how early is early? So if you look at that, we can see that over the years, with extensive research, researchers have been able to identify some of the early signs of autism spectrum disorder as early as 9 to 12 months of age, that is prior to the 1 year of age of the child. And also this progresses beyond that age till the time the child formally reaches any clinic setting for a formal diagnostic evaluation and specific intervention to be delivered at that stage. And typically in the low and middle income countries, especially in the Indian subcontinent, what are the studies that have been done have shown that there is on an average a delay of at least 2 to 2.5 years between the parents recognizing some of the concerns in the child with regards to especially the language skill development as well as the social skill development to delivery of any formal intervention in the clinical setting. So the early identification of these features of autism helps us in providing the early intervention. And all over the world, the research has shown that early intervention leads to better outcomes for the children. And the better outcomes are in the core clinical features of autism, that is qualitative impairment in the social interaction as well as the social communication, as well as the restricted repertoire of behaviors and interests. So in children who are in the infant and toddler age range, typically we look for certain early kind of concerns which parents could identify. Say, for example, below the age of 9 months, typically in terms of the social skill problems, there will be the atypicalities in the eye contact and facial expression. And there could be problems in the what we call the pre-linguistic skills, mainly in that we conceptualize the gaze disturbances as well as the attentional disturbances. And also they may have poor fine motor abilities. So these may be very early markers prior to 9 months of age. And at around 9 months of age, we see that these children, they have a problem in what we call as social orientation. That is turning and making eye contact when their name is being called. And also they have, like in terms of language development, usually by that age, children develop babbling. So these children, they may lack the babbling. And also they do not take turns in vocalizing back and forth. Also, the varied vocalizations which we see, especially after the 9 months of age, is typically absent in these children. And they continue to lack the response to the caregiver's voice as well as the environment sounds. And sometimes they keep making some unusual or high-pitched sounds. Also, we see that they may show very unusual kind of attachments, or sometimes even intense attachments, stereotypic movements, self-injurious behaviors, or unusually severe temper tantrums with transitions, or sometimes for no apparent reason. And some of the times they may start engaging in repetitive behaviors such as lining of objects in a row. And beyond this period, like especially when the child attains 1 year of age, when the parent or caregiver points to the child to an object which is lying across the room and asks the child to look at the object, the child fails to respond at that time and look at that object. And also the language development deficits persist beyond this age. Mainly the absence of babbling, and also very few vocalizations, and sometimes very unusual sounds they continue. By the 15 months of age, they start repeating whatever they have heard, what we call as echolalia. And sometimes around this age, there could be a phenomenon of regression, that is loss of some of the language milestones which have developed till that time. And by the 18 months of age, the pointing to experience sharing of interest with the parents, what we call as a proto-declarative kind of pointing, that is limited. And also they fail to engage in pretend play activities. And this further gets consolidated by the 2 years of age, that is 24 months. And mainly by this age, by 24 months, we expect the child to use 2-word phrases, which they would not have developed by this age. So these are some of the, we can say that early markers. And in terms of the tools that are available for early identification, we have some tools like the infant toddler checklist, which is available right from 6 months to 24 months age on time. And also there is a tool called first year inventory, which can be used right from 12 months of age, sorry. However, in the low and middle income countries, 3 tools have been identified and validated as to be used in the low and middle income countries. These are modified checklist for autism in toddlers, which is abbreviated as MCHAT, and also pictorial autism assessment schedule, which is called PASS, and a 3-item direct observation screen, which is called TIDOS, TIDOS. So MCHAT is from the age range of 16 to 30 months, whereas the pictorial assessment autism schedule is between 18 and 48 months, that is still 4 years. And TIDOS is between 18 months to 60 months, that is still 5 years of age. So recently, in the Indian setting, there were certain specific screening tools that have been developed. One of the screening tools is the Chandigarh Autism Screening Instrument, CASI, that has about 37 items. And also the Indian Indian Autism Screening Questionnaire, which is abbreviated as IASQ, which has 10 items, very brief instrument which can be completed within 5 minutes with yes or no responses, which was recently validated, and the results were published in the last month. So what we need to understand in this age group is picking up some of the early developmental and behavioral markers which we see in the children across right from 6 months or 9 months of age. And though we may not diagnose that child as having autism spectrum disorder, we can definitely use the term at risk for autism spectrum disorder and start early intervention. Because some of the clinicians may have this concern, and even parents often have the concern that below the age of say 1.5 or 2 years, one should not diagnose and unnecessarily give a label of autism spectrum disorder. So we can definitely use the term at risk, and we can start the early intervention in this age group.
So you have spoken, John, about the fact that early identification and early intervention actually reduces the long-term kind of impact that one has on the developmental trajectories. And you've spoken about, a whole set of tools that now some of these tools are quite easy to identify. Going into a somewhat higher age group, from toddlers to preschoolers and school-age children. I'm talking, John, about 4, 5, 6, 7, 8-year-old children with autism. The kind of clinical features that you spoke about, which are very core clinical features, that is delayed babbling, delayed language, lack of reciprocal social contact. These are some very robust indicators to have a suspicion that these are children at risk. But if you look at slightly older children now moving in the lifespan to 4, 5, 6, 7, 8-year-old, what would be the kind of clinical features or even the differences between boys and girls? And are there different tools for diagnosis? Other than the core factors that you mentioned for very young children, when they are a little older, preschool, do they have other kind of behavioral comorbidities? And then what happens to them in school, for example? And what kind of interventions do we have for them, which are either home-based or school-based? So these are some major issues, friends, which I'm inviting John to respond to for slightly older children. Your
Yes,
thoughts, John?
Yes, sir. So when we look at the age group beyond the age of 4 years, so as sir, you have mentioned between 4 years to 8 years or 9 years of age, typically before they move into the adolescence phase, we see that by this age, the whatever expected language development that would have happened in a otherwise a neurotypically developing child would have got delayed in these children. And one of the common clinical features in somebody who presents, especially in that age range, is the parents reporting to the clinician that there is a history of delay in development of language, and the child is either completely non-verbal or the child is having a very minimal kind of verbal language skills, especially expressive verbal language skills. Comparatively, there will be a delay in the receptive language skills also, both verbal and non-verbal. But the expressive language skill delay, the verbal and non-verbal, that is either in the form of using certain words or phrases or forming simple sentences that is expected by that age, or in the non-verbal expressive communication by certain facial expressions, appropriate facial expressions, which are context specific. Also, the pointing skills continue to be poor, both proto-declarative as well as proto-imperative pointing. And in this age group, another common thing which we come across is the eye contact also continues to be poor. if at all there are changes from the earlier age range, the eye contact may slightly improve, but compared to children who are in the neurotypical kind of development, these children, they have atypicalities in the eye contact. So usually it is a fleeting eye contact, fleeting ill-sustained eye contact, or the eye contact preferentially for objects rather than the faces of people. And they may be more preoccupied, especially with certain objects. Could be the color of the objects, or it could be especially objects that are rotating or spinning. They may just focus on that rather than the face of either the parents or the others. And also we see that around that age, any language that they would have developed is typically not specific to a given context, and they keep having what we call the echolalic kind of speech. Both immediate as well as delayed echolalia is possible. Immediate echolalia is something where they immediately repeat what the caregiver or parent says, or other adult person says. And delayed echolalia is whatever they would have exposed earlier, much earlier. Say, for example, if they had seen something on the screen, they might be humming the same rhyme repeatedly after a period of several hours. So that kind of phenomenon also can be seen. Also around that age, children may start having some of the other behavioral comorbidities, which sometimes masks the presence of this core autism deficits. So these include typically the presence of ADHD, which is attention deficit hyperactivity disorder. So children, they may show significant hyperactivity. Also, they may show significant problems in their attention span, and they may show poor impulse control. Unless the child is carefully observed, we may miss the features, that is the deficits in the social communication, social interaction. And many of these children initially in the clinical setting, they get diagnosed with only ADHD, and they are typically prescribed medication for ADHD. And a diagnosis of autism spectrum disorder is not considered at all. And the child continues to just receive specific intervention for ADHD. Some of the other problem behaviors that become prominent during this time are the stereotype behaviors. The stereotype behaviors can be repeated lining of objects, and also repeated rocking movements, or repeated walking back and forth, repeated walking or running around in circles, movement of a part of the body, like say, for example, the hands or the fingers repeatedly. And sometimes these repetitive behaviors could be self-injurious in nature, wherein the child may start banging their head repeatedly, or they may start biting themselves repeatedly, or they may just keep smelling some objects repeatedly or touching some objects repeatedly. So these kind of behaviors may become prominent during that period. Also, we see that this is the period when they start their schooling, and this is the first time that the child gets exposed to a different environment, school environment. And that environment becomes very new for them. So these children typically have a problem in transitioning to a new environment. So till that time, they would have been in the home context. So transitioning to the school environment would be difficult for them. And in the school, they would be seeing the teacher and some of the other children who are in the classroom, which they are completely new to them. So the teachers will be able to identify some of these behaviors in the classroom context. So either on one extreme, that child will be completely aloof, going to one corner, sitting there, not making eye contact at all, not having any meaningful engagement with either another child or with the class teacher, or child having, especially those having a mild to moderate kind of ASD features, they may engage for limited periods of time, but usually they may have significant, they usually have significant difficulties in the social interaction, social communication. And they may start avoiding certain activities, and especially when it involves the group activities, they may become uncomfortable. And in some of those contexts, the child may become very anxious also, and start having frequent stereotype behaviors. So these are some of the things that we can notice in the school-going children. And also in terms of some of the tools for identification in this age group, the childhood autism rating scale is one very common tool that is used in this age group. And also we have tools like the social communication questionnaire. And for a detailed diagnostic kind of assessments, sometimes, especially in the research settings, people use Autism Diagnostic Interview Revised, which is called abbreviated as ADIR, and also Autism Diagnostic Observation Schedule, ADOS. So both these elaborate diagnostic tools are quite expensive, and they require training for the clinicians to use in the either in the clinical or research context. So especially in the low and middle income countries, most of the centers, they may be unable to afford this and also get the clinicians trained on these tools. Though in the Western context, some of these tools are considered gold standard, especially when we want to do research in this particular age group of children, both the school-going children, adolescents, and if we have to publish our data, they may consider this. And more recently, in the Indian context, we have this tool that is developed after a study by the International Clinical Epidemiology Network, which is abbreviated as INCLIN. INCLIN tool for the diagnosis of autism spectrum disorders, which can be used right from the 2 years of age onwards. And this tool basically is based on the DSM criteria. And with the update of the DSM-5, the tool has been modified by the All India Institute of Medical Science in New Delhi, and they have validated that tool. So it is called the AIMS Modified INCLIN Diagnostic Tool for Autism Spectrum Disorders.
John, at this point, go on, John, go on.
Sir, just to add some of the interventions in both the preschool as well as the school age group children. In the early intervention domain, we have the early intensive behavioral interventions, which is abbreviated as EIBI, which has been evidence-based. And some of these interventions are based on the applied behavioral analysis theoretical framework. And also we have certain early intensive behavioral interventions which are based on the other theoretical frameworks like developmental and relationship-based frameworks. And of late, especially in the both in preschoolers as well as school-going children in the low and middle-income countries, there is a lot of emphasis on what we call the parent-mediated early interventions, which also is an advantage in many of these countries because the multidisciplinary resources, professional resources for center-based interventions is in many of these countries, low and middle income countries, is restricted to the major urban centers. And so many of the children, they lose out on the interventions, the quality interventions. And that's where recent research points to definitely adding the parent-mediated early interventions to the whatever center-based interventions that are available. And these parent-mediated interventions, they work on the premise of the clinician initially working using an intensive collaborative approach with the parents and training the parents so that they can deliver the targeted intervention to the child in what we call as naturalistic kind of settings in the home context, wherein this is incorporated into the daily routine of the child so that these interventions can be provided on a regular basis by the parent or caregiver.
That's quite a comprehensive kind of framework, but it brings us to a point where I think it would be good to take some questions that have already started coming before we move to the next part of the lifespan, which is adolescence and adulthood. A very fundamental question, John, which has come from Vinita Tyagi, which is the question is very simple. What is the difference between autism and, of course, she uses the term mental disorder, but I suppose mental disorder could encompass the difference between autism and intellectual disability and autism and early onset mental illness. So the question has two parts, essentially. What is the difference, or how can this difference be made out in a given child? How do you know that a particular behavior is because of autism and not very early onset, let's say, schizophrenia, or it's not intellectual disability with some concomitant behavioral problems? Your thoughts on this, John?
Thank you, sir. So, yeah, this is a very pertinent question. And so if you look at the historical aspects of autism spectrum disorder itself, this confusion had existed in the initial period when Leo Kanner in 1943, he described this condition. The professionals at that point in time, they didn't easily accept this new entity. And many of them felt that this could be certain other conditions which Kanner is probably confusing with. One of the conditions is what we call as the childhood onset psychosis, or very early onset psychosis, wherein later research has, by especially the Colvin and team, had shown that in the case of very early onset psychosis, the onset before the age 3 or 2 years is relatively uncommon. And typically, such a very early onset, that is below the age of 3, with clear social communication, social interaction deficits, is probably related to this condition which Kanner had described. And also, if we look at many of the diagnostic classificatory systems, whether ICD or DSM, interestingly, the till DSM-2 and also till almost ICD-9, the condition of autism that was described, those days we used to call it as pervasive developmental disorder, was subsumed under the psychosis with the onset in the early childhood. And only subsequently, that is from ICD-10 onwards, and also in DSM system, the DSM-3 and DSM-3 revised onwards, this became a separate entity in the classifications, and people started recognizing the differences between autism and some of the early onset mental illness, especially childhood onset psychosis. Having said that, some of the recent neurobiological research has identified neurobiological, especially the brain imaging research and even genetic research has shown significant overlap between all these conditions. So in terms of some of the biological markers for all these conditions, there seems to be a significant overlap, whether it is autism spectrum disorder or intellectual disability or early onset psychosis, or conditions like tic disorders, which again have been recently classified as neurodevelopmental disorders. So are some of the conditions with neurological kind of symptom, very early onset epilepsy, etc. They seem to share some of the common biological, neurobiological substrates. And also, only thing is the phenotypic manifestations may be slightly different. And oftentimes, we see that the comorbidity rates are also high, especially when we study in the clinic population. So what we need to understand is clearly these are not watertight compartments. And this especially the neurodevelopmental disorder construct is something that has expanded rapidly in the recent years. And many of the conditions which probably we assume that they are mental illnesses recently, like say, for example, early onset schizophrenia and all, they also are on the neurodevelopmental spectrum if you look at one of the schools.
There are two other issues related to this aspect, John, before we go on to the next part of the life cycle. And the next part of the life cycle I would actually predicate it on a very interesting issue that Shubha Badami has actually put on chat. And I'll start with that when I come to the next part of the life cycle, but still staying with toddlers and school going, that spectrum. There are two issues. One is a question raised by Devyani, which is the issue of speech delay and autism, the extent to which they are related. And speech and articulation problems that are of non-autistic origin, speech issues that are related to intellectual disability, and the core issues of autism. So this is one issue. The other is a very interesting issue, which is actually raised by Utkarsh when he asks about our experience of, in fact, you know, there is a term that he uses, which is an interesting term, which is a COVID baby. 18 months to 2 years, children presenting with the ASD features in the background of understimulation and excess screen exposure. That is when you see them longitudinally 18 months, 20 months, and 22 months. So in these kind of people, and you can see that a lot of questions related to this are coming in, that what early intervention should be initiated for the toddler in autism. Is excessive crying related to autism, from Bhupendra Gurung? And Subodh Gupta is asking, when they grow up, and Subodh, will come to that when we really look at the adult manifestations in terms of comorbidities and conduct symptoms that you're actually talking about. So we'll come to that in a bit, and we'll park both Ms. Badami's question and Subodh's question when we come to the later section. But John, your thoughts on the speech delay part of it that Devyani has raised, yes, and what Dr. Jayanta speaks about early stimulation, excessive crying, and Utkarsh's point on the whole COVID understimulation issue. John?
Yes, sir. So the speech delay is, we can classify that under the what we call the communication disorders, wherein it could be, as I mentioned earlier, like somewhat more prominently the expressive language delay, and both verbal and non-verbal, and sometimes it's a mixed expressive receptive language delay. And this is something as clinicians, all of us need to keep in mind. And presence of speech delay is probably one of the features of autism, but presence of speech delay in itself is not autism. So autism is definitely, it encompasses the other things also. So the presence of qualitative impairment in social interaction and social communication is a must. And in children with speech delay, there could be like for example, some of them may have the receptive language quite well preserved. And also we see that the non-verbal component of speech may be relatively well preserved compared to what we see in children with autism. And they definitely will not have the restricted repertoire of behaviors and interests what we see in children with autism. In one way, we can say that probably all these conditions lie along a spectrum with the speech and language kind of impairments, specific speech and language impairments at one end, and the presence of a diagnosis of or feature suggestive of a diagnosis of autism spectrum disorder at the other end. And there could be several variants. That's why the autism spectrum disorder itself nowadays, like if you look at the diagnostic criteria also, one of the specifiers is with or without language delay. Because earlier the conceptualization was definitely they should have a delay in development of language. Whereas we know that sometimes the delay may not be very prominent or even may not be reported by the parents. And sometimes it could be just atypicality in the language communication. So that is about the language delay and the autism spectrum disorder. Coming to the question by Dr. Utkarsh, that's a very interesting question on the understimulation that probably these children would have encountered during the COVID pandemic. So this amounts to what we call as an experiential deprivation, because due to the situation caused by the COVID pandemic, the lockdowns and all the restrictions on travel and outdoor activities, the parents, they would have remained at home, and or even the situation would have been the one of the parents working, the other parent is busy with arranging certain household kind of things, and or the child left with a caretaker with very minimal, even not going to a play area outside, not even encountering another child that we would have seen over the last 2 years, wherein that play especially and the social interaction would have severely got restricted. Some of them, they may start showing features suggestive of autism spectrum disorder. And if the children have clear features that as per the diagnostic criteria, we can definitely make a diagnosis of autism spectrum disorder, both by clinical history and a detailed behavioral observation. But however, we have to inform the parents that this is probably one of the factors, though we can't say that it's not so simple saying that this factor has led to autism or this is a causative of autism. So it's autism spectrum disorder is not such a simple, doesn't have a cause-effect relationship with any specific factor. But we can say that it is one of the risk factors in this child. And we will have to follow up that child and see whether after this experiential deprivation improves over a period of time, whether the child continues to have these kind of features like beyond, say, 18 months or 2 years of age. And some of them continue to have these deficits, whereas some children actually they are able to improve significantly. And there is a term that is used called moving out of the spectrum. Sometimes they may just not meet the diagnostic criteria of autism anymore. So both these outcomes are possible in these children.
So to go now into the second half and the other part of the life cycle, I'd really like to start with a very interesting issue that Shubha Badami has raised. And the question really is development of autism or the expression of autism at an older age possible with normal development earlier, as in neuroregression. And perhaps, John, we can use that as a base to really speak about ASD in adolescence as regards its diagnosis, its comorbidities, concerns related to transition into adolescence, challenges for the caregiver and parents, which Dr. Subodh Gupta has raised. Is there any evidence that of the outcomes in older adolescents and young adulthood, and what kind of support systems do we have? Now, this is a very interesting issue because for very many practitioners, what happens is that our contact with children with a diagnosis of autism or autism spectrum remains at the age of 1, 2. We see them up to the point that they are 3, 4 years old. And it suddenly strikes me 5 months after I have retired that some of the children that I had diagnosed, Poonamji, can you put your system on mute? Thank you. Thank you. Poonamji, can you please mute your mic? Can someone from IT please handle it? Thank you very much. IT? IT, can you handle it, please? Thank you. So, and I suddenly wondered that what happened to these children 10 years later, 15 years later, 18 years later?
So,
we have never followed them over a lifespan. So, John, your thoughts on adolescence relating to what Shubha Badami has mentioned?
So, thank you, sir. So, when we look at the older children and adolescents in the clinical context, we come across few scenarios which I'm sure that all of you as professionals would have come across in your respective clinic settings. One of the things is that one possibility is that these children would have had very mild ASD features during the childhood, that early childhood period, and the diagnosis would have been missed by the clinicians, and or it could be the other way around, like wherein the family would not have sought any formal clinical consultation at any point in time. With the common misconception what we have, that the developmental conditions over a period of time they'll improve. This is one of the common misconceptions which people usually have. They won't seek help, and we may come across this child suddenly by the age of 10, 11, 12, etc., with initial presentation with probably a comorbid condition. So the child would have developed features suggestive of ADHD, or child may have certain challenging behaviors, may not be amounting to a diagnosis, like especially stereotype behaviors, or child may have certain other developmental issues, like say the learning difficulties, etc., wherein during a clinical assessment, we would pick up this incidental kind of presence of ASD. That is one of the possibilities. The other possibility is, as I think the person, like the professional who had asked the question, she had pointed out, like wherein there is an initial period of normal development or typical development till the age of at least 2 years or 3 years in some cases, and after that a child starts developing a regression in development, especially related to the language developmental domain as well as the social skills domain. And this regression initially, unless it is a very severe or gross regression, or if it is manifested in the presence of other neurological symptoms like seizures, etc., it may not be very readily identified. And by the time it fully manifests, the child would have already reached, say, beyond 7 or 8 years of age. So that is one possibility. And in those cases, we can see that the parents typically they report that my child was, or our child was all right earlier, and we never had these kind of problems. But suddenly, we see that he's been talking less, he's not interacting with other children, he's not, he's very particular about his routines, or he's showing repetitive behaviors, etc. So in these contexts, we can identify these children. And otherwise, like the question which sir had asked, saying that those whom we identify either in the preschool age or when they are probably in the 4 to 6 years age group, what happens to them during their adolescence? Especially those children who receive early intervention and who receive this continued intervention during the periods of say 3 to 6 or beyond that till say 7 or 8 years and into adolescence, they tend to have more favorable outcome compared to those who have not received any early intervention. By favorable outcome, what I mean is that definitely by the adolescence, these children have significant improvements in the social communication as well as social interaction, and also in the restricted repertoire of behaviors and interests. And for those children who especially have average or above average intellectual functioning, and say by age of 4 or 5 years, if they have the language development, especially the expressive language development, more so the expressive verbal language development, to be mildly impaired, those children seem to have, they are likely to have more favorable outcomes during the adolescence. Having said that, we should remember that as we are discussing today, that this is a condition with a lifelong kind of presence. It's a neurodevelopmental condition. It doesn't just magically disappear by the time the child enters adolescence. So as an adolescent also, they continue to have some residual deficits in all the core domains, that is the social communication, social interaction domain, and also the restricted repertoire of behaviors and interests. However, in the adolescence period, it may manifest differently because during that time, there could be the additional comorbid conditions. There is a high risk of the adolescent developing conditions like depression, anxiety disorders, ADHD, tic disorders, eating disorders, etc. And these manifestations may be the initial presenting features to the clinician. Also, we see that Sir mentioned, like many of them, they are lost to follow-up. They are not, they are not attending the regular clinic services, and more so in the low and middle income countries, there are no specific clinical services provided for these children, especially the older children, adolescents with autism, or the young adults with autism. That's where we lose track of them, and they don't attend follow-ups. And some of them, due to the behavioral issues, if they have, or due to depression, anxiety, and the related impairments in functioning, especially in the academic functioning, or in the behavioral aspects, especially in the classroom context, if they have issues, they get referred from the schools for a formal assessment. At that time, while we are thoroughly evaluating them, we may identify this autism. And then we may tell the parents that, this is the condition that I have identified. But parents may say that earlier this was never formally evaluated and diagnosed. And then probably that would be the kind of baseline point for us to deliver the interventions to this adolescent.
As we come to the last part of the life cycle, just to respond to a couple of other issues that have been raised, which address themselves to this part of the life cycle that John has spoken about, the infants and the toddlers, the preschoolers, school age, and sometimes persisting into adulthood. One of the issues that Shakila has raised, for example, is a social communication disorder, sensory processing disorder, and autism spectrum disorder. Do they come under the same umbrella? And can central auditory processing disorders and post-traumatic stress disorders, can they mimic autism spectrum? It's a very complex question, Shakila and friends. The issue is that the earlier belief that autism was a protean single disorder, as opposed to this whole notion of it as a spectrum or as a behavioral end expression that can lead to the phenotype which we see in terms of speech and language, social responsivity, and restricted repertoire behaviors, and so on. So to go back to a point that Subodh has also made in the chat, that doesn't regression point towards degenerative disorders and not autism, that regression syndromes, friends, do occur in the background of either neurological or degenerative disorders. Landau-Kleffner syndrome is one of them, post-epileptic speech and language regression, or even some which are progressive, like SSP or other such disorders. But they may have, or Rett syndrome, for that matter. Some of them, we know the genetic, the genotype as well. The exact genetic basis is known for some of these disorders, but they can present with autism-like symptoms. The idea, therefore, clinically is to be aware to see whether the behavioral phenotype is associated with other markers. And that's why we, other than clinical assessments, there is now the clinical trend to go into, clinical diagnostics and so on. So, yes, the interest that speech and language people have, what Dr. Ratinavel points out as the relationship between smartphone usage before 2 years of age, very similar to the question that Utkarsh had raised, which, even a normal child, if that child is put in an environment where nutrition is ensured, but there is no play, there is no stimulation, will develop odd behaviors. That this is not to say that excessive smartphone use by itself causes, autism. And, particularly with the pandemic, this is an issue that we need to keep in mind. And this is where, Rathinawel, the point that you make about the joint family and avoiding smartphones. In fact, the American Academy of Pediatrics, the Indian Academy of Pediatrics have come up with guidelines for under 6 years of age, how much of screen time. So they prescribe that it should be 60 to 90 minutes or whatever, and that too not continuously, in 5 or 6 divided over a day, 15, 20 minutes. 6 to 9-year-olds, perhaps 2 to 3 hours. 12 to 16-year-olds, 4 to 6 hours. So that's how you kind of work with this situation. Then, John, there are many other questions that are coming in, which we will take towards the concluding part. But so I have noted these questions. The question about lockdown, the question from Poonam about ADHD and medication, the question from Dr. D'Souza from Setu about really presenting a clinical situation, again mentioning ADHD, anxiety, learning issues. So I've noted these questions and we'll take them in the concluding part. But going to the last part, John, which is ASD in adults. What are the diagnostic challenges, comorbidities, outcome-related issues, and what kind of treatment do we have for adults with autism spectrum disorder? John?
Yes, sir. So as far as the adults are concerned, they are, like at least in adolescence, there may be some continuity with the child and adolescent kind of services, and few of the adolescents, as I mentioned, may get referrals. So few of the adolescents may get referral from the school context, etc. But in the case of adults, we see that that opportunity is very limited for adults, and we don't have any dedicated services for adults, not just with ASD, but with neurodevelopmental conditions. And many of the general adult psychiatrists or even the general physicians and other specialists to whom these adults may visit, they do not routinely screen for any neurodevelopmental conditions, leave alone autism spectrum disorder. So can I request people to kindly mute themselves? There's a lot of background noise.
Thank you. IT? That's Madhu Kumari. Thank you. Yes, John.
Yes, sir. Sorry. So the adults basically, like they may present, like in the case of adolescents with comorbid disorders, especially problems related to depression, anxiety spectrum, and also eating disorders. And some of them may have the residual, like especially if they had ADHD along with autism in the childhood and adolescence, the residual ADHD symptoms may be present in those adults. And also we see that the comorbidity with some of the medical neurological kind of conditions also is high in autism. That is something we need to remember, like close to 15 to 20% of children, adolescents, or adults with autism, they have comorbid epilepsy. So sometimes the epileptic seizures can become very frequent and even treatment refractory. Also, in some people, actually, there could be the underlying genetic syndromes that are related, that present with the phenotype of autism spectrum disorder. So some of the common syndromes include Fragile X syndrome, Down syndrome, Angelman syndrome, etc. Or even neurological conditions like tuberous sclerosis, neurofibromatosis type 1, etc. So the presentations, clinical presentation initially may be with the neurologist or with the general physician, may not be directly with the psychiatrist. And other important issues in the adults is that many of them, they like in the case of adolescents, how we see that in the school setting, they may have significant problems in adjustment with the peer group. And also they may have the academic difficulties. Due to behavioral difficulties in school context, they may get bullied repeatedly. They are often victims of bullying and other forms of, especially the emotional abuse from the peer group or punishment from the teachers. Adults, similarly, they may face like, because it's a double-edged sword kind of thing, wherein they themselves have the social skill deficits, but they may themselves face social isolation, stigmatization from the other adults, both in the neighborhood where they live and also in the workplace. And many of them, actually, they are not able to have sustained workplace functioning. Many of them, they frequently change jobs, or they may have low productivity in the workplace. And few of them actually with average or above average intelligence, and especially some skills like where they may be very good at, say, the computer activities or etc. They may gravitate into some of these professions where they may become, say, for example, very good web designers, or the software developers or content developers, etc. in those kind of fields. In fact, one of the I think it was Professor Simon Baron-Cohen and team. So they had proposed that probably a large number of these adults, they may work in the IT industry, like wherein that social context may be very limited, and they are just happy sitting in front of the machine and working. And sometimes they may be very creative, actually. So some of them have developed very innovative kind of software programs or apps, etc.
Thank you, John, for that. Now, let's take some concluding questions, and I put them to you for your response. I'd actually like to combine a set of 3 questions because they kind of relate to each other. As I said, one of the issues that came initially from Poonam Vadva was this whole business of a child with ASD who also has attention deficit hyperactivity, and what is the extent to which the appropriate medication will actually help. Now, if you look at this question in the context of what Dr. Surovi Patra asks, which is about the COVID lockdown and the extent to which it affects child development in the Indian context, and then triangulate these 2 issues with the major issue that Dr. Nandita has raised, which is really a pragmatic clinical challenge, shall I say, because with the pandemic, schools have opened, and there are many referrals that many practitioners are having from primary and middle school with learning issues. But when they are assessed, they have ASD, they have ADHD, they have anxiety, and they have learning challenges. Now, whether is this because the teaching culture itself went out with COVID? Is there a lack of proper teaching or lack of adequate experiences? And so when we have these multiple diagnoses, the challenge of offering effective management without, this, what Dr. D'Souza calls as throwing families into a diagnostic minefield, to allow them a reassurance. How do we make this balance, John?
Yes, sir. So we all know that autism spectrum disorder per se is a complex neurodevelopmental condition, and the comorbid disorders across the lifespan, different comorbid disorders, they occur with varying prevalence, and some of the disorders, like say, for example, ADHD or depression, anxiety at different age levels, the studies have reported high comorbidity rates, almost 1/3 of children, and even beyond that, like say maybe 40%, 60%, etc. However, like in the clinical settings, when we are doing a evaluation of these children, one needs to be cautious whenever we are making any additional diagnosis, whether it be another developmental condition like intellectual disability, ADHD, tic disorder, etc., or any non-neurodevelopmental condition like depression, anxiety, eating disorder. So only when they reach a diagnostic threshold, the other disorders have to be diagnosed. Not in the case of those situations where there may be subsyndromal features or symptoms of some of the conditions, but they don't reach the diagnostic threshold. So underdiagnosis is a problem of co-morbidities. Similarly, overdiagnosis also can happen sometimes, that the clinician needs to be cautious. And also that's where I think having multiple sessions with the child as well as with the family, observing the behaviors of the child in detail, and using some of the relevant tools for assessment of comorbidities. Say, for example, the schedule for affective disorders and schizophrenia present and lifetime version is called KSATs, KIDDY-SATs, present and lifetime version, or the mini kid, etc. And taking a detailed developmental and behavioral history. Also getting the school reports, that's very important. Certain symptoms may be more prominent in the school context. So doing all those things and then communicating with the family members about this diagnosis and telling them that it's common because that something has to be highlighted. Otherwise, as Dr. Nandita pointed out, they may get very worried, saying that earlier it was just one condition and their child has got additional conditions, one after the other, and the clinician seems to be diagnosing multiple conditions, and they are also pretty confused, like in terms of intervention also, which is important, which is more important, which is less important, and specific interventions like, say, medication interventions. Is there a role with one condition more than the other condition? And even the non-pharmacological interventions, how exactly to provide in this situation?
There are a couple of related questions that I'd like to take together, John, before there are some very, very specific and interesting questions, which really is I suppose, an indication of how autism is still enigmatic to many people, including practitioners. But I'm referring to the question raised by Dr. Jayanta Poddar on some kind of a roadmap or a guide to early intervention, both pharmacological and behavioral. And when we speak about pharmacological, I want to relate this to an issue that Dr. Shakila has raised, which is that many of you are aware of this whole set of literature on autism and its relationship with the gut microorganisms. So is there a relationship between gut microorganisms and the whole protocols that are available? Are there biomedical interventions? But people are also asking, would medication cause other problems? Would they cause eating problems? How do we assess progress as far as therapy is concerned? Your thoughts on this, John?
Yes, sir. So there are few biomedical theories of this particular condition. So related to this gut or GIT, gastrointestinal tract, there is this leaky gut hypothesis, which says that some of the toxic substances from the gastrointestinal tract, they leak out from the intestines and they enter the bloodstream and they travel to the brain and they cause the altered functioning of the brain, and sometimes over a period of time, if it happens, probably bring in some changes in the microarchitecture of the brain also. resulting in the manifestations, behavioral manifestations, and also developmental kind of manifestations, what we see in children with autism. So that is one of the theories wherein to address that, providing certain treatments, like say, for example, chelation therapies to remove the toxins from the blood, or giving certain supplements to increase or improve the local gut, what we call maintain the homeostasis of the gut. And one of the other theories is the gut microbiome theory, where certain microorganisms in the gut which are supposed to have a protective role, they seem to have depleted, and so replacing that microorganisms in the gut region. So even nowadays we are familiar with some of the therapies which have been done, like stool transplantation or fecal transplantation, you can call, from healthy kind of individuals to individuals with ASD. And people claim that by doing these kind of interventions, there have been improvements in both the developmental aspects as well as the behavioral aspects in ASD.
Well, thank you very much, John. And to very quickly address many of the issues that have been put on chat before I hand you over to June to close the session, I must say that it is both a credit to the commitment of the participants who have joined the session today, and indeed to the challenges and enigma of the disorder, that almost 90% of the people who logged in have stayed the entire duration of the program, which is usually not the case. There is an attrition to the tune of 20, 30, sometimes 40%. And I think this speaks a lot about the interest that the disorder has for people, as indeed the commitment and the of all the professionals who work in this area. So very quickly to respond to some of the issues here, starting with the last one, Shakila, OT, PT, occupational therapy and related techniques are very much used in developmental disorders. Surabhi, very few studies on Indian studies on Indian literature on adult autism. We had a publication on Asperger's, which we haven't spoken about today. John referred to in passing when he spoke about the IT industry. So very few studies, but there is a paper from Asperger's that, and this reminds us that we really need to address this issue. A lot of questions raised about concomitant sleep disorder with autism. Do they have sleep rhythm disturbances? That and indeed many children with autism do, because of their sensory processing issues as well. But between using lifestyle management to using grandmother dietary regimen to activity-based regimen to daily routine to very severe sleep disturbance, where you may have to resort to medication, I think one needs to keep a pragmatic approach in mind. And finally, Sadhana, as far as, Dr. Hema, social phobia and selective mutism and school phobia come more under the anxiety spectrum disorders. Some of them anxiety in very young children sometimes may manifest in social skills deficits, but they are usually okay within the family setup. It's only in situations where they are unfamiliar that, and Shakila, the whole point of dietary interventions, your omega-3, super Nuthera, hyperbaric oxygen, all that has not stood the test of time. And I also have kind of noted there are scales and tools which actually look at therapy improvement. which you administer, 3 months, 6 months, 9 months, and you look at scales which specifically look at what is called as response to intervention, the RTI kind of scales. Maybe Samvad will consider putting together from chat a whole set of FAQs, and we put them on our website. And finally, Sadhana, about leg shaking, just on a lighter note, I know of many very personable mental health professionals who are incorrigible leg shakers. And having said that, it is my pleasure. Thank you very much, John, for joining us today and for an insightful session. And thank you to all the participants for your enthusiasm. It is because of your participation and enthusiasm that Monday Moods with Samvad comes alive each time. I will now hand over the session to June for closing. Take care, everyone else. Rest well and keep in touch with our social media handles. We will be back with more sessions on Monday Moods and indeed many other programs that Samvad does. June, over to you.
Thank you very much, sir. Thank you so much, Dr. John and Dr. Shekhar, for taking us through this comprehensive understanding of autism spectrum disorder. And of course, thank you so much for the ones who have joined us today. Without you, without the questions that you have asked, we wouldn't be able to have such a wonderful and enriching session. And last but not the least, we would like to invite you all to our next session, which will be on the 18th of April. The topic is on transparency and inclusion. So we'll be talking about the key imperatives in supporting children with neurological disabilities. And we hope to see you all and have a great evening. Yeah, thank you so much.
Thank you.
Namaste.
Thank you.